Welcome to Quality, where we are exploring quality in emergency care. This is your host, Arjun Venkatesh. Today's episode is the next in our series of our venous thromboembolism initiative of the Emergency Quality Network. I'm joined by the co-lead of that project, Dr. John Sather, and our special guest today is Dr. Peter Steele, who is Vice Chair of Clinical Services at Weill Cornell in New York City. Welcome to the show, Peter.
Thank you. Thank you for having me.
We've been talking about a lot of different things when it comes to VTE on this show. In prior episodes, we've talked about guidelines. We've been talking about, new research that's coming out, things like that. Today was to really get into some of the more details about how this is not only sort of turned into practice, but where this might be headed, given a lot of the innovative stuff it sounds like you're all doing in your shop. And, one of the things that's really hard about managing patients with VTE is not just necessarily the diagnosis part, which we spent a lot of time on. Sometimes it's not, there are ways to get better, but it's not just the decision to anticoagulate them, but it's sort of everything that comes after that. A PE or a DVT doesn't just go away like a finger dislocation. It's with somebody for some time, maybe for life. And so those care transitions become really important. But when I say the word care transitions, I'm probably losing half of our listeners off the bat. Tell us why you're so into this area and why these care transitions matter so much for these VTE patients in the ED.
I think I'd like to start by just talking a little bit about the exciting frontier of care transitions in this patient population and grounding it really in understanding what the downstream consequences of VTE can be in patients. And one is post-thrombotic syndrome. So the idea that a simple DVT can cause long-term venous outflow obstruction, deep venous reflux, which can result in chronic long-term sequelae, pain, swelling, reduced quality of life. And that there are actually exciting new interventions to reduce this risk of venous incompetence, particularly in iliocaval DVTs, proximal DVTs, and that's predominantly venous stenting. And venous stenting has been shown to impact these quality of life issues, pain, swelling, ulcers, and that these venous stents stay open for the vast majority of the time. There's actually a federally funded ongoing study measuring the performance of these stents that's ongoing. The other piece is thrombophilia testing, and that's not needed in every patient with DVT, but certainly in a patient with unprovoked DVT or more than one DVT, certainly a DVT through anticoagulation, or DVTs in an uncommon location, they may warrant a more detailed hematology workup, precision medicine, if you will, to screen for genetic traits or formal thrombophilia. And that's usually started about 3 months after anticoagulation. So none of these frontier transitions of care are urgent, but it would be good for them to happen in the next few months. And these are offered as, if you will, advanced diagnostics and therapeutics for these patients. Other parts of standard of care outpatient VTE management is just primary care follow-up. They need longer-term anticoagulation therapy prescriptions. Some primary care physicians are doing repeat sonos to try to determine when anticoagulation can be discontinued within 3 months. But that's particularly important for superficial thrombosis or thrombophlebitis, where even the DOAC may not be required. And then for patients with subsegmental PEs, they may warrant an echo for further risk stratification of the cardiac impact of that otherwise small PE.
Yeah, Peter, that's just hearing you kind of talk about the next steps, in particular DVT management as an outpatient. I'm sure some of our listeners feel like we got enough on our plate, right? Just to get the diagnosis right and do it wisely, resource conscious, and then kind of get the patient the immediate treatment they need, right? Sometimes we feel like that's kind of our job, but more and more, I think we are, as was mentioned on an earlier podcast, the fulcrum. We connect these patients to their next step. And sometimes that next step is not obvious and puts a burden on us, but I think it's a responsibility that we need to bear. What are some of the themes in terms of barriers to getting patients to those next steps that you mentioned that are so crucial?
Yeah, great question. I mean, I think overall there's a gap between the vast number of ED patients who would probably benefit from the limited transitions of care resources EDs have, and those resources that are available, particularly in busy urban emergency departments. And I would offer that this gap between resources and needs typically warrants a hierarchy of post-ED needs. So which of your patients are you going to spend that extra amount of time ensuring that they have strong transitions of care plans, and that whether it's a social worker, a nurse practitioner, and a community healthcare worker that's in your department helps get them there. And I would hazard that hierarchy should perhaps include patients who were started on high-risk medications, where medical compliance is a need to have, not nice to have in terms of the health outcome. And in patients who need close follow-up for further diagnostic or prognostic testing. So using that construct, I would say post-DVT patients are the types of patients who we should have a timeout and maybe have a more dedicated approach to discharging and coming up with a care plan in the setting of this busy, chaotic ED with multiple demands on our providers, as you correctly identified. I think it starts with comprehension. With regards to a high-quality ED discharge process, in a study recently, demonstrated that providers spend approximately 2.7 minutes discharging their patients. And imagine that after a prolonged, stressful, unscheduled acute care visit. So on the front end, I was emphasized that this is a group of patients who need all of their test results, a detailed explanation of the diagnosis and the disease trajectory, and the importance of the management, the importance of the medication. Again, it's not a nice to have, it's a need to have medication. And the critical next steps in their care, and have enough time for the patients to get their head around all that information and answer questions and confirm that they understand. And in vulnerable communities with limited health literacy or English language proficiency, this discharge may take a while. And again, I think that's okay, because this is a high-risk population we're discharging. This is a cohort of patients 10 years ago, a lot of EDs were probably admitting. So I think just a conceptual paradigm shift to say this is a patient who's going to need more time to land the plane or close the encounter, I think is really important.
It's an interesting nuance, and it's important because we have a lot of medical directors and quality directors who listen to the show and are leading equal projects across the country. And, all of them, I'm sure, face universal pressures, both external regulatory as well as internally, to do everything they can to shave any minute off of ED length of stay, right? Try to get every patient discharged faster as a way to reduce your left without being seen rates, get people out of the waiting room faster. We're in really crowded EDs. So I have to think it's hard to look at people and say, even for the same person at the leadership role, let alone all your docs in the pit, and say, hey, slow down, take more time for these patients. How do we tell that story?
There's limited literature in the impact of improving or refining the discharge process has on health outcomes. The limited research that's out there by ED physicians does show that improved comprehension of and perhaps compliance with the ED discharge encounter reduces the number of avoidable ED return visits. And there's one paper that shows it reduces hospitalizations. So I think to answer the question, does a good ED discharge matter? I think the limited research out there is, yes, it does matter. So I think the story to tell is that this is a critical intervention. How we initiate transition of care, how we discharge the patient or land the plane, changes their health outcomes, or has the potential to change their health outcomes perhaps more realistically. It's as critical an intervention as making sure the prescription for the antibiotics is the right dose, or that the x-ray is for the elbow and not the wrist. I think we really have to conceive of the ED discharge as a discrete intervention that matters.
Yeah, I think there's three components you're kind of describing, all of which contribute to the overarching barrier. The first is clinician awareness of next steps, right? And I got to admit, prior to talking to you, and I know we've talked a little bit before this podcast, I don't even think I was aware of kind of the downstream impact of appropriate follow-up for someone with a DVT diagnosis. I think probably like many ED docs, I make my diagnosis of a low-risk DVT, start them on a DOAC and send them on their way without an appreciation for that sort of precision medicine approach, which may really help many patients long-term. Then there's the component of, do I have the time to sit with my patient and explain all of that to them, how important it is? And then do I have access to discharge them into a place that can enact that? So any suggestions for our listeners about kind of how to tackle those three challenges?
Yeah, I mean, so let's talk a little bit about how do you effectively coordinate multidisciplinary care from the ED. And I think it's very difficult. And for those centers that have a lot of resources, you can punt this case to your social worker and have already developed a workflow for them to help navigate this DVT or PE patients' transitions of care. But many of us don't have 24/7 case managers or social workers available. So in one center, we developed a collaborative email group where the ED provider could email this listserv, and it would be collected by both interventional radiology, by the primary care clinic, as well as hematology. Again, some of those resources, ideal state, some essential, the primary care physician, and that they would then subsequently reach out to the patient. And so you can put it onto your specialty and primary care outpatient providers to collaborate with you. This is business to them, so it should make sense. Many places, I think, struggle with timely access to outpatient care, and that's a real problem across the nation. But I would encourage ED operational leaders to consider engaging with your CMO and other executive stakeholders to recognize the monetary value of an avoided low acuity admission. So again, 10, 15 years ago, we were admitting these DVTs and these subsegmental PEs to hospital, and that's a relatively low acuity, low reimbursable admission, far lower than, say, a cardiac catheterization. And that perhaps framing this cohort as we could admit them, but we'll discharge them if we can get expedited outpatient primary or hematology care, we'll leverage the C-suite to help these outpatient facilities to prioritize our post-ED patients. And we've been successful like that. So I'd say one, a collaborative multidisciplinary team approach that can be coordinated by a single touch of an email. And secondly, engaging executive stakeholders to understand the value of high intensity, rapid outpatient access to avoid a low acuity and low reimbursable admission. That's speaking the C-suite language, right?
Well, I think that's exactly what I think our medical directors out there need, which is, what's the ask? What's the ask they need to make of their CMO? And, as you're saying that, Peter, it quickly harkens in my mind all the thoughts about TIA. Everybody will probably say they have a TIA clinic, and they say TIA clinic, but it's not like a TIA clinic is a magical place. There's no MRI machine there. There's not some special TIA diagnostic tools. What a TIA clinic really is exactly what you described. It's just a facilitated, guaranteed, rapid follow-up for a patient that had an acute visit in an emergency department was determined to have a TIA. And so in some ways, it sounds like what the ask is to say, hey, every time we've got a DVT or PE patient in the ED who's suitable for outpatient care, we need to have a quote unquote VTE clinic, which is really just, people, place, and that place could be virtual or real probably, that's going to ensure that the care continuum continues.
Yeah. Yeah, and this can be tiered. Our VTE clinic includes this precision medicine hematologist and an interventional radiologist to consider stenting these proximal DVTs, but it doesn't have to be that complicated. It can be as simple as a primary care physician that's going to ensure that patient's DOACs are refilled and that they get a repeat sono in 3 months or whenever is appropriate. But insurance is also a fluctuating issue. I mean, now when DOACs first came out, most insurance didn't cover it, and I think they rapidly caught up. And now most insurances cover at least one of the DOACs, although there's variable copays. So confirming the patient's ability to fill scripts prior to discharge is another sort of core ED responsibility. Now, some pharmaceutical reps have utilized various coupon strategies, but be warned, they're usually up to 30 days. So that patient, the impoverished patient or the patient with limited insurance, getting them a free script for 30 days may seem like a win on the surface, but if they don't get their primary care follow-up to ensure that there are further strategies to make sure that they have the meds, then I think we're doing the patient a disservice, because long-term compliance here is the key. That's what's going to affect the patient's outcome, not short-term. Which begs into the question, the duration of how long an ED provider should write a script. And we've talked previous discussions about the historic 7-day supply of medication, be it pain medication or antibiotics. And it may worth be considering a 2 to 3 month supply from the ED provider for these patients. It's going to be contingent on how, from a systematic standpoint, how quickly you think you can get your patients follow-up.
That's a really big point, because I think, I don't know, maybe I'm biased in my thinking about this, but I think that a whole adage of, this comes from the world of patients who are hypertensive in the ED, who we're discharging home, and we've evolved in our clinical policies and our guidelines and our research to say, hey, we can safely do that. But then there's often this, I feel like I hear from my colleagues, well, let's just write them a 7-day script, because that way they'll guaranteed to follow up. with the assumption that if it's sort of enabling somebody, if you write them a prescription for too long, that they won't follow up. But I think that's misguided. That's not what keeps people from following up. The reason they don't follow up is because they just cannot get an appointment. Right? We have lots of research that shows whether you're even commercially insured or Medicaid insured, certainly it's even worse if you have public insurance or no insurance, but even if you're commercially insured, that it's impossible to get an appointment 7 or 14 days after an ED visit. And so I think going back to what you said before, which is if we want to do the right thing for the patient, we need to be writing them for a lot more than 7 days of anticoagulation.
Yeah, I think the first question is how quickly can we get them follow up, and then grounded in that knowledge, in servicing our frontline ED providers to write scripts to reasonably bridge that gap. It's also worth noting that fill rates from the EDs are imperfect. I think you had quoted to me previously research demonstrating ED fill rates are 70%. So ensuring patients both understand the importance of this therapy and screening for any barriers is key. And social determinants of health screening in emergency medicine is not yet standard of care, and maybe it shouldn't be. We don't want another unfunded mandate. It's not a stretch to imagine how transport or housing instability or financial insecurity may impact outpatient VTE management. And at my institution, we're lucky enough to have patient navigator program, a group of community healthcare workers that schedule vulnerable patients for appointments, matching their insurance to the provider, or if they don't have insurance, referring them to the National Recovery Service for emergency Medicaid, and screening for social determinants of health. Now, not everybody has that generous group of resources for screening in the ED, but this is a cohort that if you think the patient is underinsured, utilizing the NRS, the National Recovery Service, and understanding what their barriers could be to accessing outpatient care is going to be important.
Yeah, I think this gets to that theme too, just our changing responsibility as emergency physicians and understanding the system in which we work. And I still would adhere to the idea that many of us sort of think we make a diagnosis, we tell the patient what the diagnosis is, we prescribe a medication, the DOAC, and say it's really important for you to follow up, and then out the door they go.
Yeah,
and I would say that's fairly standard. And then we rely on them. And some of the discussion we had before is, well, if we only give them 7 days, they'll definitely, when they run out of their medications, pick up a phone and call a primary doctor. But that's not the case. And I'd like to see us move to a model where we kind of pull them into our fold, particularly for something like VTE. Like, as you mentioned, this is a potentially lifelong diagnosis, fraught with a lot of downstream complications. We know that they have it. They've had an ultrasound or a CT with a small PE, and they're going home. Shouldn't our system have a responsibility to go seek them out, right? Don't leave them a number to call. Shouldn't we be reaching out to them? And I think that's sort of a changing paradigm a little bit that the health system in general needs to adopt.
I don't want the audience to be daunted. Again, the hierarchy is not as large as it seems, or the denominator from that hierarchy. I mean, of the patients we're choosing to discharge with a VTE, some of them will be of means, and this will be a brief conversation, and they're going to call their PCP tomorrow. Some will have to do a fairly high touch on, but this is a subgroup of patients who we're going to discharge. And I think it's about managing our team to understand where the risk lies in our treat and release cohort, and that a DVT-PE patient without immediate access to care is a high-risk group and worth using our limited transitions of care resources for. And spending a little bit of that extra time, of our limited extra time in emergency medicine, making sure they understand the consequences of non-adherence to their long-term health.
Yeah, in some ways, I know we started this talking about a lot of the precision genomics and precision medicine concepts around VT and how that changes the downstream care. The same could maybe even be said around the social determinants of health. There was an SAN consensus conference this year around precision medicine, and there was a whole workout table there around precision social emergency medicine. It was getting at exactly this concept, right? Which is that we have a limited amount of resources. And so just like there may be somebody who has a certain genetic type in whom anticoagulant medication may work differently, you also have people with different social determinants of health phenotypes in whom different social interventions may modify the outcome differently. And so I think it's, not just targeting for genes, but it's actually targeting our entire treatment plan for the patient that's in front of us.
Yeah, I couldn't have said it better. I mean, it's funny in a way to reflect on this conversation. It's kind of demonstrating the two focuses of healthcare in general and emergency medicine is how can we advantage the frontier of technology and of advancement in healthcare. And at the same time, how can we shore up the most vulnerable patients to make sure they're getting at least the standard of care, if not above and beyond that. So yeah, this kind of reflects those two frontiers in healthcare.
Well, Peter, this was great having you on today. I learned a lot. My brain is a little bit more open to all these innovative ideas and innovative things you guys are doing in your shop. And I hope that our listeners as well have sort of, take a little bit of a different view in their quality improvement projects locally around VTE to start incorporating some of these principles, and particularly for our sites who are focused on new projects to improve discharges for low-risk PE. I think there's a lot of nice content and ideas there that align well. Hope to have you back on the show in the future, and best of luck with all the ongoing work that you're doing there.
Yeah, and thank you all for your great efforts in this project. I'm really privileged to be a part of it. Thank you.
Peter, thanks.